Hello, everyone, and good morning. This is Manos Poulakis from Minneapolis Heart Institute. It's a great pleasure to be here today with Dr. Alexandre Avran, who is the head of CTO program at the Arnaud Jank Institute in Nice, France. Dr. Avran is one of the world-class CTO operators who's done tremendous progress in both doing cases but also educating people. And it's a great pleasure to have him today in the 26th Complex Coronary Intervention webcast. Thank you so much, Alexandre, for being with us today.
Thanks, Manos. Thanks, everybody. It's a great pleasure to be here with you today. I'm working in France. Arnaud Jank Institute is one of the French reference center for all complex PCI, so also CTO procedure. So today I want to present you some cases about one complex PCI situation, the ostial RCA occlusions. And Manos, as I know that you are a great fan of algorithm, I created one, my personal algorithm for ostial RCA occlusion, and then I will show you with several cases how does it fit.
Perfect.
Okay, so this is my algorithm. So the first point is there a guiding support in ostial RCA? Sometimes you have, sometimes you can't. And I will show you with different examples how we can manage this situation with this algorithm. So the first case, as you can appreciate, it's a 57 years old man with an history of PCI on LAD on ostial RCA in 2010. And as you can see, it was impossible to select the ostial RCA because the previous stent is outside the ostium, so inside the aorta. So the best projection we can have is this one. If you now get inside my algorithm, you can't have some guiding support in the ostial RCA. So you are on the right hand, and then now the only way to begin this case is go in retrograde first. So that's what we have done. And the next situation, when you go retrograde first, sometimes you can also have some integrated wiring. But in this situation, so before I will show you the retrograde filling, so there is a great connection from septal to distal RCA. So in this position, integrated wire wasn't possible. So we are now in this tree. So the only way is to externalize the retrograde wire. So the plan for this patient, we work in right femoral 7 French and right radial 6 French. First microcatheter was micro 14 and go surfing with Cyan Black. So I know Cyan Black is not already available in the US, but
it's coming.
Yes,
we'll be there in a few months.
And it's a great innovation for me. It's you can see the Cyan Black now is reaching the distal part of the RCA. Micro 14 is coming.
Is that your go-to wire for retrograde crossing through septals?
Now, yes. Now, first it was the regular Cyan, but now Cyan Black is more slippery. So it's very, and for epicardial also, it's very good. So at this point, I always made a tip injection to appreciate the distal cap, and we can see that the distal cap is inside the beginning of the ending of the strut of the previous stent. So this part there is some difficulty because the micro 14 was stuck. So I need to exchange him for Corsair, and then with the Corsair I can with Gaia second retrogradely, and it was very easily to advance the Gaia second until this point, and it was near the ostium, and it was very hard to get outside. And in fact, when I'm working trying to get outside with the Gaia second, the Gaia knuckle, and I use this knuckle because I was inside the stent, and push with this knuckle, and you can see the knuckle is going to, now is up and go outside the aorta. So with this technique, you are sure being not inside the strut because you are knuckling your wire.
And that the Corsair gave you the support, right? Because that's not support you need to push the knuckle.
Absolutely. So it was very important to advance the Corsair at this point. And then now you are in the position that your retro wire, you can go inside the guiding, or so you are into the aorta. So the only way is to snare it. So I could advance my Corsair, then exchange the Gaia for RG3, and then snare the RG3, and you can see the snare. And then predilatation, antegrade predilatation. It was the first time that we can cannulate the antegrade guiding. So with the support of the retrograde wire. And so balloon 2.5, 3.5, and then it was a BMS stent. So we put a GS. And this is the final result. So the time of the procedure was 80 minutes. So you have all the data, fluoroscopy time, contrast, and radiation for this patient.
It's a phenomenal case. I guess shows the challenges with having a flash occlusion. So here, retrograde worked very well. You got true, and everything was great. So that's your go-to technique for all these flash ostial RCAs from now, right?
Absolutely. So let me present you the second case. In that case, it's also an ostial occlusion, but as you can see, I get some support with my left arm plates on the right. And so there is nothing to see when you do the bilateral injection on the right. But with the bilateral injection, we can appreciate that the occlusion, the length of the occlusion is not so long. So on my tree, you have a guiding support on your ostium. So you are on the left part of the tree. And then the next question is, are you able to cross with an antegrade wire in the true lumen or subentinel? So here I work bifemoral approach, 7 French, and go first with a confianza and a fine cross. So I used in that point the confianza because to puncture the proximal cap, and I need to use it without pushing because the support was present but was not so good. So if I will use a Gaia, for example, I need to push a little bit more than the confianza to penetrate, and the problem is to get outside the ostium with my guiding catheter. So in that situation, I was not so confident because, as you can appreciate, the confianza, I don't know if is in the right direction or not. So I just puncture the proximal cap, then exchange for feeder XT wire. And the feeder XT wire takes some bend, but there was no extrasystole, so I just redirect my feeder XT, and with some drilling, it gets easily in the true lumen. So this is a curve on the right, but with the feeder XT is a soft wire, so you can use it. I use it a lot, feeder XT, in that kind of sometimes calcified, bending, curvy artery. It's a good wire to take the curve for all this situation. So then now I was able to advance my fine cross and then exchange for another wire. So my wire was able to cross true lumen, so then you have to finish integrate. So I advance, but in fact now I realize that there is another occlusion at the distal part of the RCA. So I first predilate the ostium because the problem of support was like this solved, then stenting, and then I have also the distal part of the RCA, another occlusion. So I am with my fine cross and just exchange for a Gaia second, and a Gaia second was able to cross inside the distal part, and then we finish the case with some post dilatation, and yes, this is the final result of
Beautiful.
This RCA.
Beautiful, and I guess it's an example here where trying undergrade first, although it didn't look very favorable with all the calcium, by doing the escalation, you actually got a very nice result without having to go retrograde or do other more complicated techniques. So that's a great example. Is that your typical go-to when you have an undergrade channel, a puncture with a Pro 12 and then downgrade to a softer wire like the Fielder XT that you did in this case?
No, it depends. If there is a tapered proximal cap, I can go directly with a soft wire. But if it's a blunt stump or I feel that I need some puncturing, yes, it's my work.
Great.
So next case, it's also a difficult case. This case, it was a patient with some graft, but the patient was hadn't graft inside on the RCA, so it was a big guys, 114 kilograms. GCTO score was 5 because it's also retry. Left ventricular function was low, 30%, but MRI show us inferior viability. And so we are here. My integrate guiding as a support. So we are also in the left part of the tree. So next is my wire is crossing true lumen or not. So in that point, so use the Corsair and Confianza Pro 12, and then it was impossible to stay inside true lumen. So my Corsair was in subintimal. Surely after several trials, stay subintimal. So the point here now, the question is, do I have a good support in my subintimal space? So if yes, I can knuckle and then use ADR strategy. If not, my feeling is to lay this wire in place and go retro, and you have the wire in your good position for a reverse curve technique. So here, with a Fielder XT, I was able to knuckle. So my Fielder XT progress in the subintimal space.
Looks like getting good support, and you were able to get way down.
With my yes. So you can see in the down slide, I will advance the Confianza with my knuckle. Now I have a good support, and I in the good position for my landing zone, as you can appreciate on the up slide. So we are now ADR positions. So my crossboss is coming. So is just in front of the landing zone at the distal part of the RCA. Then I change for a Stingray balloon. So as you can see, the marker was in the good position. So you have 2 points, 1 line. So then with the retrograde injection, you can appreciate that you have to puncture at the upper side of the Stingray. So with Stingray wire, now you select the upper hole and just push and try to feel the release. So I feel the release with the Stingray wire, and then with retrograde injection you can see that the Stingray wire is not inside the true lumen, but it passed through the lumen. So then turn with stick and swap technique. So exchange the Stingray wire for Pilot 200, select the same hole, and it was more easy to navigate with the Pilot 200 inside the true lumen. And then I reach this distal part with my Pilot. So this is the final result. So 90 minutes procedure, 45 fluoro time, 2.7. So it was a big guys. So
this is a great result, and you say very efficient. And that's the nice thing about undergrad dissection reentry, that it's very efficient in terms of going down, getting your efforts, and re-entering. And you said that's a pretty short period of time for being able to do such a complicated case with all the calcification.
Yeah, absolutely. So in post-cabbage cases, dissection reentry, I think, is one of the gold with the retrograde.
Sure.
So fourth case, it's also difficult cases. As I remember, you can see it's a very calcified RCA. There is some retrograde feeling from the LAD, but the distal part of the RCA is very diseased also. But the patient was a lot of ischemia. My support was not possible. So we are in the right arm. So retrograde trial first, and I am able to put an antegrade wire inside. I will show you. So femoral and radial approach, GCTO score 4, very calcified. So I get with Corsair, and it's regular science this time, and find a way inside this septal channel. Then at this point, I advance my Corsair at the distal cap of the occlusion, and as you can see, it was very, very calcified. So the only way is to puncture the distal cap. So I use Confianza Pro 12, puncture, and then just advance the Corsair 1 centimeter inside the distal part of the RCA. And so we have a roadmap of this artery because of the calcification. But to progress inside, it's very difficult. So I prefer using a retrograde knuckle. Then be sure staying inside the architecture of the artery. So it was a feeder XT knuckle, and then I can advance my Corsair. At this part, in retrograde wire was a Gaia second, then Pilot 200, and antegrade. I was able now with some maneuver to introduce one a Progress 200. It's you know
Sure.
Progress,
Yeah.
and with a small balloon because it was impossible to get with a bigger one. So it's a 1.5 balloon, and try to do a reverse cut technique at this point. Then I work with it's Jet 25. It's a wire from Abbott, but it's not a CTO wire, but it's a nitinol wire, a polymeric one. So sometimes it is very useful in this some difficult situation.
Long length you can externalize. It's a long wire.
Yeah, you can also. Then I deflate the balloon, and during the deflation, my wire was able to get outside the aorta. So here the point is I tried to get inside the guiding catheter and not using a snare. So just moving your GR4 and try to put in front of your wire. So with this maneuver, you need to be two operators, because you can't use at the same time your wire and just moving your guiding catheter. So you need to work with some guys, and then you get inside. So it makes life easier now. So advance the Corsair inside. In that situation, I trapped the Corsair because I wasn't able to advance more my Corsair inside the guiding. So I was afraid to lose all this position. So I trapped the Corsair. So I get back with the Jet 25. It was Jet 25. And then inflate the balloon so it traps the tip of the Corsair inside my antegrade guiding catheter, and then exchange for RG3. And when the RG3 is coming, just deflate the balloon and let the RG3 go in the externalization way.
That's a great point. Do you routinely do that for your retrograde cases, or just in the ones you have poor
No,
guides?
a lot of my retrograde cases, I use guide liner or guide technique. So using the rendezvous technique, in mainly of my procedure. But in that situation, it wasn't impossible to introduce a guideliner, and if I was able to advance my corsair more deeper inside the guiding catheter, I will not use this, but
Sure.
it was impossible. So
Sure.
it's good.
Safety
It's some
measures.
tips and tricks to know. And then predilatations.
Yeah, we actually had a case like this. We didn't trap it, and then we lost it,
Yeah,
and then we started all over again. And that's painful. So
yeah,
I completely
that's
agree with
why. So finally, the final result is the disease was the distal part of the SCA was diseased, but now it's open, and for this patient, I think it will help him for his ischemia.
Yeah, this is a phenomenal case, and also here you said is you had the severe calcification and very proximal disease. Essentially, how to drill your way back and coming out. But the nice thing is you could do a balloon and do a reverse card, modified reverse card in a way here, right? If you couldn't get a balloon in, then you do like the first case, just try to push the wire out as much as you can.
Absolutely, but the difference with the first case that we have no stent inside.
Yeah.
So if you push and you are subintimal, it could be dangerous.
Sure.
So and the last case is it's also a difficult case. It was ostial RCA occlusion. The RCA was dilated 3 times at the ostium. So first without stent, then BMS stents, then restenosis inside the stent, and finally always reocclusion. And we are now with guys with a very, very symptomatic angina, with inferior ischemia, and this is the point, or the stent was not outside the ostium, but the occlusion was always here, because I think there is a residual stenosis inside the stent. So it's a calcified, and maybe we forget to use rotablation before stenting this case. So here the plan was to try to cannulate the right, and as you can appreciate, it was also impossible. So in the tree, the only way is going retrograde. So retrograde filling was present. So we are here, retrograde. Antegrade wire was impossible to advance, so going the straight retrograde. So it tip injection from a corsair. Then cyan black. So cyan black is coming and just surfing.
Black is a very slick wire.
Yeah.
It goes many places.
Yeah, yes. No, it's so good. So it's a real time. So sometimes it's easy to get to the right. So cyan black was able to advance as far as I can, and you can see
all the way to the ostium.
Yeah. So my corsair was still in the beginning of the septal, and I was able to, with the cyan black, so going true lumen to true lumen and then outside. It was very so the length of the occlusion was very, very short. It was only at the beginning of the stent, at the part where we were in trouble with. So then. Two possibilities, then snare into aorta, or try to get inside your guiding catheter with your wire. So we do it. with my friend Laurent Drogoul. I work a lot with him in Arnaud V Institute. So we work with 4 hands. And so he moved a little bit the GR4, and I try with the cyan black to get inside and then we succeed.
Perfect.
So at this part, we advanced the Corsair and exchange for RG3. And we are now in this situation. And the problem is that it was really difficult to advance a balloon integrate. So we decide to advance the Corsair inside the GR4 guiding catheter and then exchange RG3 for rota wire and do a tip-in. So so this is the rota wire and the tip of the Corsair, and you see I try to get inside the Corsair with my rota wire up. So now you are in, up, and now it's easy. The rota wire is in place. Then you remove your Corsair, and you are now integrated situation, and you can use a rotablator. So it was a beer, I think 1.5, and it was a difficult situation because the rotablation place was just at the ostium inside an old stent, but it was the only way to create a new situation for a new stenting. So then we can predilate and stenting, and this is I think the final result.
This is great, and actually I've seen sometimes people do some laser, like if you couldn't get your microcatheter all the way in the guide, which can happen, they can do laser or something else.
Absolutely.
But it's a great example, and it looks like rotablator, even if there's no stent, there's so much fibrotic tissue and there's no other way, so they can really make a channel for you.
Yeah. So as a conclusion, so every CT operator knows that ostial RC occlusion is a very challenging situation, and so I think this kind of algorithm could help its teaching point from new CT operator to know if do I go retrograde first, integrate. So with this several example, we can see that we can go integrate in ostial occlusion. Sometimes it's impossible when you have no guiding support, so the only way is retrograde. But after retrograde, you can also snare or go inside directly the guiding catheter. Or integrate, you can go integrate only wiring, or ADR situation if you are good support. So that's what I want to expose you today.
Thank you, Alexander. This was a phenomenal presentation. As you said, this is something that's very common. It can be very stressful for people, and obviously requires experience in all techniques, retrograde, antegrade dissection, reentry. So it's for advanced operators doing these very complex cases. But I really like your algorithm. I think it breaks it down to different discrete steps and makes it easier for people to follow a pathway and have plan B if plan A doesn't work. So I think it's a wonderful algorithm. It would be great to have it published, so we're excited to see the publication coming out for the algorithm. But really appreciate you doing this webcast for us today.
Thank you very much.
Great, thank you.